I'm going to turn now over to our moderators for the next session, Saul Weingart and Marie Carmel Ellie. Please take it away.
Thank you, Andy. Hello, everyone. I am Marie Carmel Ellie. I'm the professor and chair of the Department of Emergency Medicine at the University of Alabama at Birmingham. I'm joined by my co-moderator, Dr. Saul Weingart, who is the president of the Rhode Island Hospital and Hasbro Children's Hospital. We're pleased to moderate this session on the impact of COVID-19 pandemic on diagnostic pathways, perceptions about diagnosis, and settings of care. So addressing both the existing endemic and novel infectious outbreaks has largely been predicated on the operational and clinical pathways established over decades of established scientific investigation, public health policy, and organized medical practice across the globe. In 2020, as the world was informed of this novel respiratory illness, scientists and clinicians became acutely aware of unique challenges in discriminating the COVID virus from other endemic pathogens, the challenge of managing the lack of existing diagnostic platforms required for global dissemination, and the unclear symptomatic characteristics associated with the infection. Ultimately, this had a consequential impact on patient-centered bedside care as well as systems delivery. We're honored to welcome our speakers today who will allow us to reflect on lessons learned in characterizing a new disease, the consequent impact of the outbreak on our healthcare systems, and the discoveries and opportunities leveraged by using our digitally enabled care pathways. So in this morning's session, we will be hearing from three speakers. First, from Dr. Michael Osterholm. He's a director at the Center for Infectious Disease Research and Policy and Regents Professor and McKnight Presidential Endowed Chair in Public Health at University of Minnesota. And he'll be describing the lessons learned from rapidly characterizing a new disease. Next, we'll have Dr. Nicole Franks, Professor of Emergency Medicine at Emory University School of Medicine and Chief Quality Officer at Emory University Hospital Midtown. She will be discussing the health system perspective on changes to the diagnostic process. And then finally, we'll have Dr. Renu Kishal, who is the Senior Associate Dean of Clinical Research and Chair of the Department of Population Health Sciences and the Nanette Laitman Distinguished Professor of Population Health Sciences at Weill Cornell Medicine. She'll be describing opportunities of the digitally enabled care pathways. As a reminder, the speaker bios can be found on the workshop website. And with that, let's go ahead and start the presentations with Dr. Osterholm.
Well, thank you very much, Marie, and I appreciate the opportunity to be with you here today. Let me just start out by saying that in terms of my role today in the context of this entire meeting is really to try to focus on that initial discovery. And really, I'll cover primarily the first year of diagnostic challenges and opportunities to give you a sense of where we may look at any future situation with a new emerging pathogen, or even today how we interpret where we're at with SARS-CoV-2. I think it's very clear, and as Dr. Rubin laid out very nicely already, the etiologic agent responsible for causing pneumonia cases in Wuhan in December was determined to be a novel coronavirus on January 7th, following the sequence of lung fluid. As someone who was very involved with the SARS outbreak investigation of 2003, as well as MERS in the Middle Eastern area, as well as in Samsung Medical Center in Seoul, Korea, this was actually good news for me. I thought, wow, we can handle this since the vast majority of transmission associated with both SARS and MERS occurs well into the clinical illness. If we find patients quickly, we can isolate them and actually interrupt transmission quite substantially. Well, that changed over the course of the next 4 to 5 days as we got more information that no, it was very likely that in fact individuals who are asymptomatic were transmitting this virus and that it was actually spreading quickly and far. We had a number of contacts on the ground in the Wuhan area, and it was very clear and apparent. So my initial enthusiasm for this finding went into more of a, oh my God, this could be like influenza. By January 10th, the reference genome was assembled and published. As we know, on January 13th, the WHO published initial protocols for real-time PCR assays, and they also opted for the use of real-time PCR tests developed in Germany, which had 2 primers. In no time, the entire world is trying to get their hands on resources for these molecular-based tests. Might add, just as a side note, that on January 20th, our center actually put out a statement stating that, in fact, we had seen sufficient evidence that we believe that this would cause the next global pandemic and that the world needed to be prepared. Well, while testing capacity was initially limited everywhere, some countries like China and South Korea were able to ramp up capacity relatively quickly. As we know today, China was capable of conducting about 1.6 million tests a week by the end of February. Around the same time, South Korea, which held meetings between regulators and executives of 20 different medical manufacturing executives earlier that month to find solutions, had conducted tens of thousands of tests. However, many other countries didn't have the same level of success. Low middle income countries were at a disadvantage from the very start. Per WHO recommendations, handling and testing of COVID specimens should be done in a BSL-2 laboratory. In some countries, there were very few facilities that met that criteria. For example, Nepal had only one lab equipped for COVID testing in the entire country at the beginning of the pandemic. In addition to labs, real-time PCR testing requires complex and expensive machinery, which couldn't be scaled up and shipped overnight. As an example, in April 2020, Roche reported that one of their fully automated PCR machines included approximately 23,000 components sourced all over the world with 101 sub-assemblies and a total assembly time of approximately 150 hours. Final production of these instruments takes place in Switzerland in factories that would take months or years to replicate and equip. So for low and middle income countries initially looking for that type of support, clearly they lacked the machinery necessary in many instances to conduct PCR testing, which was not readily available. Even in countries that did have proper machines and specialized equipment necessary to conduct PCR testing, they would need trained technicians to operate them. Thus, in the event that physical capacity is expanded, places might still be challenged by the availability of qualified workers, not to mention the necessary PPE that they would need to wear, including gowns, masks, goggles, etc. Finally, on top of all these things, you still need the various supplies and reagents required to collect, store, transport, and test the samples. This includes things like individually wrapped and sterile single-use swabs, test tubes, vials with caps for storing samples, chemical solutions that preserve the samples prior to testing, specific reagents for RNA extraction, DNR primers, and fluorescent probes, etc. Global manufacturing and supply for each of the above items was not at all capable of meeting much of the enormous and sudden demand. Bottlenecks quickly appeared in the complex web of supply chains that the world relied on for these items. An analysis conducted by the consulting firm McKinsey & Company in May 2020 found that the large majority of the RNA extraction kits and our real-time PCR test kits were being manufactured in China. In fact, China's capacity to produce reagents in bulk, making them cheaper and more attractive prior to the pandemic, caused many of the companies who relied on them for supplies to enter a bidding war. As a result, many of the low and middle income countries that had already relied on imports due to the lack of domestic capacity to manufacture and conducting tests were outbid, and essentially they were sealed off. At the same time, supply chain bottlenecks affect every country and was constantly changing. A spokesman for the American Chemical Laboratory Association spoke to the volatility of shortages, saying at one point it was test kits, at another it was swabs. But one constriction in the chain of supply can suddenly create a bottleneck, bringing it all down. To cope with these bottlenecks, some turn to things like 3D priming, printing swabs, or using different transport mediums to preserve samples. However, for the most part, access across the world was largely limited until supply could better catch up with demand. Of course, although improvements have been made by now, we're still 2 years into this pandemic, and many parts of the world are still extremely vulnerable to a lot of similar challenges: whiplash in supply and demand, lack of domestic capacity, etc. If I just focus for these last several minutes on the U.S. overview and what happened here, we all know we were challenged. The U.S. was not spared from many of the supply chain disruptions mentioned above. However, the country encountered their own separate challenges early in the outbreak. Following publication of the SARS-CoV-2 genome, the CDC opted to develop their own real-time PCR assay instead of using the WHO-endorsed assay. By January 20th, the CDC had developed the test which looked for 3 specific regions of the virus as opposed to the WHO test that looked for only 2, and began testing samples at selected airports in the country that received flights from Wuhan. On January 21st, the first U.S. cases were detected in the state of Washington in a resident there who had recently returned from Wuhan. On January 31st, HHS Secretary Alex Azar declared the outbreak a national public health emergency. Although this granted the government more options for responding, it also placed testing at the discretion of the FDA and its processes for emergency use authorization. On February 3rd, the CDC submitted the UA package for their test to the FDA, which was issued the following day. On February 5th, the CDC began sending test kits that they had developed and assembled to state and local public health labs. However, shortly after tests were distributed, several labs, including ours here in Minnesota, reported issues that arose from validating the test, particularly with one of the reagents. Less than 1 week after test kits were distributed, the CDC announced that there were issues with some of the tests and told states experiencing problems to stop using them and instead go back to sending samples to the CDC lab in Atlanta for testing. As a result of the country's limited capacity, the criteria used for testing was extremely narrow, with no one allowed to get tested unless they had recently traveled to China or had been in contact with an infected individual. With little or no improvements in the situation, the Association of Public Health Laboratories sent a letter to FDA Commissioner Stephen Hahn on February 24th asking the FDA to grant the APHL members the ability to use their own test. In the APHL letter, they said the following: "We are now many weeks into the response with no diagnostics or surveillance tests available outside of CDC for the vast majority of our member laboratories. We believe a more expeditious route is needed at this time." On February 26th, the same day the U.S. announced the first case of suspected local transmission, the FDA announced that state and local health labs could once again use the distributed CDC test, but in a modified manner, use the 2 functioning primers and ignore the 3rd faulty primer. The following day, a meeting between HHS, FDA, and CDC officials concluded with participants agreeing the FDA should loosen the EUA regulation and allow certified labs to deploy their own tests. At this point, the U.S. had conducted less than 500 total tests. Let me just repeat this. In the first virtual 2 months of this situation, we had conducted less than 500 tests in the United States. On February 29th, the FDA issued an EUA for the first non-CDC test. Over the next month, nearly 100 labs were granted an EUA for tests. According to data from the COVID Tracking Project, average daily tests in the U.S. increased as following. On March 1st, about 42 tests a day. April 1st, 103,000. May 1st, 297,000. June 1st, 423,000. And by July 1, we were at 670,000 tests being conducted per day. On June 15th, a report from the HHS Office of the General Counsel that reviewed the potential mishaps of CDC cited possible contamination as a reason for testing challenges. Eventually, on December 15th, 2020, an internal CDC review was published in the journal PLOS One, which offered more insight of the agency's early issues with testing. The CDC test contained a flaw in its design that resulted in probes sometimes binding to one of the primers, conducting a fluorescent signal that caused false positives. In addition, the agency confirmed that the test kits were contaminated with synthetic fragments of SARS-CoV-2 genetic material that would have been used for validation. As a result of technical flaws, regulatory hurdles, business as usual bureaucracies, and a lack of leadership at multiple levels, the U.S. was unable to conduct widespread scale testing between late January and early March. However, as mentioned above, the U.S. testing efforts would still be challenged by supply chain challenges. In 2020, the American Society for Microbiology partnered with the Association of Supply Chain Management and sent weekly surveys to CLIA-certified labs between September 11th, 2020 and January 15th, 2021, 12 weeks. For each of the 12 weeks, at least half of the 147 labs responding to surveys reported shortages of COVID test kits and consumables. Range the week of January 8th, 2020, 57.5% of responding labs reported shortages of test kits and consumables. However, the week of September 17, 2020, 86% of responding labs reported shortages in test kits and consumable. Many labs have also continued to report shortages of non-COVID testing supplies. For example, during the week of January 8, 2021, the following percentages of 147 CLIA labs reported supply shortages in the following area. 35% of labs reported a shortage of supplies for molecular detection of sexually transmitted infections. 47.5% of the labs had lab shortages for the detection of routine bacteria. everything from pneumonia, bronchiolitis, and strep throat. 29.4% of the labs had shortages for mycobacterium testing. 8.8% of the labs reported shortage of supplies for routine parasite testing, and 19.4% of the labs were short on supplies for routine fungal testing. In each instance, the labs referred back to the fact that it was indeed the COVID-related SARS-CoV-2 testing that was causing these shortages to occur. So one of the things when we think about diagnostic testing and we think about new infectious agents, we also have to think about what is the impact of not only the testing for that particular agent, but what does it do to our entire universe of testing? Well, let me just conclude by saying, first of all, that I believe, based on the course of the last 10 to 15 years, once the clinical and epidemiologic evidence supports the disease is caused by a previously unrecognized pathogen, we actually get the diagnostic level of and characterization of that organism fairly quickly. I don't think today that we see months and months of inability to detect that, much like it took us with Legionella and Legionnaire's disease in 1976, or HIV. I think we're doing a much better job globally. But in terms of then implementing how diagnostic testing is used in our communities, how it's available, how is it in fact available throughout the world, is a much greater challenge. And today I know that we'll be talking about that more later in terms of the implications for basically including this kind of diagnostic testing within our everyday clinical practice. So with that, I'll conclude, and thank you very much for having me with you again today.